What is chronic bronchitis?
Chronic inflammation of the bronchioles.
Constant inflammation.
So we have an inflammation of the bronchioles. What does it usually produce?
Mucus.
When we say inflammation, what is the inflammation process in the bronchioles usually?
It creates like nasty, sticky green mucus.
Production of mucus.
Mucus, right? So it's going to have a massive increase in mucus. So it's commonly displayed with a cough associated with it, right? So you have a cough, and how do we describe this cough?
Productive.
A productive cough, right? So there are two kinds of coughs that we really look into, right? We have the productive cough that is clear, and we have the productive cough that is green or yellow. Yeah, would you agree? Yeah, we kind of, that's telling us two different things, right? What is that telling us? Let's talk about the clear one first.
There's just mucus in there. It's not infected.
Yeah, so we have just inflammation, right? We have inflammation, mucus production. Produces a cough. What if it's nasty, yellowy, greenish, brownish?
Infection.
Influenza.
Indication of what?
Maybe the flu
Or
Infection.
So infection. So what kind of infection?
Pneumonia.
See, just throwing out big words there, Dustin.
talk.
Yeah, I've noticed. So when you get a change in color, so one of the key words is like, oh, hey, you've had this cough, have you been producing anything? Yeah, okay. Has it been dark in color or has it been clear? Oh, it's been really dark. Okay? So then what are we going to do?
What color was it? Put a mask on.
How long?
Mask on everybody, mask on you, mask on me.
How long's it been going on?
How long's it been going on? And what's one of the key things to differentiate between
Why do you call it?
bronchitis versus pneumonia?
The lung sounds, one's diminished or
Temperature, right? So you have the infection, which is going to cause the pneumonia, which is going to cause a fever, right? So most people with just normal chronic bronchitis or bronchitis, a lot of times they don't have a fever. Now, is that saying that they will never have a fever? No. But commonly they do not have the fever. And the big way to be able to differentiate between the pneumonia and the bronchitis is you're going to have a fever and it's going to be dark in color, right? So if somebody has a slight fever and light in color, can things start off with bronchitis and develop into pneumonia?
Yes.
Because if you don't produce and get all of that mucus out, where does it go? Does it go up or down?
down.
Goes down, right? So everything usually will start off and just slowly make its way out, right? So that's where it sits there and it starts to develop the infection part of it. All right? So productive cough, when it turns into bronchitis, or when it turns into chronic bronchitis, what do you think would be how would we differentiate between regular bronchitis and chronic bronchitis?
Like the time that they've had it.
Productive cough.
Did you just turn them off?
What?
Too
You
cold?
got
I turned
cold?
them to 3. Well, she's over here like, I feel like it, yeah.
Maybe like shorts and tank top for you.
Maybe.
Flip-flops?
I thought we
Oh, wait,
discussed
no,
where
you
you're
can't wear
sitting.
flip-flops.
Yeah.
You need to bring your own little fan. It's a little
I thought we discussed one of those little squirt bottles.
I think-
Yeah. To the window.
I got a stroller fan. I can just click
There we
right
go.
here and, yeah.
Maybe you should.
So when it comes to the chronic
I
bronchitis,
did.
usually it's some sort of productive cough that never truly goes away. Okay? So there's two different ways that this has been presented, where it says if you have a cough for more than 3 months a year, for 3 consecutive years, I think is what it is, that it's considered. Has anybody heard that
Oh
one?
yeah,
Yeah.
so I think it's more than it's
Oh,
either
he knows
it's either
it.
2
Wait,
or
hold
3
on.
months for 2 years.
Yeah.
2 or 3 months or 2 years?
Or you
Yeah,
have it.
that's what I found.
No, but
Okay.
I did the
Yes.
Yeah, you have it.
So you have for 2 or 3 months, so basically back to back
2
years, you have it in the general same months of the year.
So 10 months you want.
Sorry.
Okay.
Yeah. And so they have it as that, or you just truly never ever get rid of it. It's always, you always have some sort of slight productive cough, and it may just be this thing where it's No matter what you do, no matter what meds you're on, no matter what steroid treatments they've given you, you're always gonna just have this increased mucus production, okay? So you're gonna get wheezing on exhalation. Does that present similar to asthma?
Yeah.
So how are we gonna differentiate between the two?
History. Our full picture.
Blue bloater.
Asthma's not gonna have any productive cough in their history.
Okay, are they gonna have a cough though?
Yes,
Mhm.
yes, we could.
So I heard somebody, had the question about isn't it Ronchi?
The wrong guy.
Ronchi, the wrong
Not
guy.
the wrong guy.
What do you guys think about that?
Will be more fluid.
Boy, I like the silence.
I don't know if I can tell.
So, hey Amanda, so that's a very good question because you've stumped your entire class.
Is it?
So it can absolutely present like Ronchi, right? So think about that production, right? How much mucus production there is, right? So the more mucus production you end up getting, everybody's staring at you. The more mucus, no, it can absolutely. The answer is yes. The answer is yes. So the more mucus production you get, the more wet your lung sounds get, okay? And so the difference between having pulmonary edema versus Ronchi is very hard to differentiate. And so this is where having that history involved, trying to figure out, because a lot of times congestive heart failure can present just like bronchitis or pneumonia, okay? And so having that history to be able to differentiate. So it may be to the point where you're so full with fluids, what is this?
I think they're trying to do that. No?
Am I making hand gestures up here?
I will stop. I'm sorry. Be constructive.
Now class. This is how we're going to teach.
Yeah, we're just gonna get all these little mannerisms out of the way. We already got rid of your
No,
squirt
it was
bottle.
not about you. It was me trying to learn NLS, but I was doing it this way, which is blunt.
Wait,
This way.
What?
It has nothing to do with your hand gestures.
Alright, well, I'm just gonna stand right here the whole time. Alright, so if you end up with too much fluid in your lungs, it's gonna absolutely present. So the early stages, or depending on how fine the inflammation is in the bronchioles, so your upper bronchioles are probably gonna be wheezing. Lower bronchioles, this is where if it has developed and begin to ooze down into the lower portion of the lungs, then you're gonna start getting the fluid sound down below, okay?
So they're gonna be like hair rubbing together.
So it's not quite like that. Actually, maybe if I get a couple minutes at the end, I'll pull up some of the lung sounds so you can listen to the differences in lung sounds. Have you guys had that yet at all in anything?
Just on our own.
We did
Just-
EMT.
Not in spots.
Okay. So we'll pull some of those up here at the very end.
Can't you tell if it moves as well? So like if they're sitting up versus if they're laying down and they're in all fields versus the bottom fields?
What's that called?
Pulmonary edema.
The status shitty.
So if you have shortness of breath while you're laying down versus sitting up with apnea, we talked about that. So similar type of presentation. So yeah, so fluid moves, right? So asthma, it's not going to change going up and down, right? It's going to be constantly constricted throughout versus fluid. So you could have the potential of not a lot of fluid, you move, transition, fluid sinks down. So a lot of it is going to be in your history. History. Once again, we go back to that history card of making sure you know the history, ask the history before you start your treatment. A lot of times they're overweight. You can see they call these the blue bloaters. They're just obese. A lot of times they're just chronically sick. Poor activity, because what happens when you start breathing a whole bunch doing exercise? So say you're a little bit sick, you have a little mucus buildup, and you exercise.
And it's gonna start coming
Have
out.
a real productive cough.
It gets very productive and you're able to get it all out. So a lot of the sedentary population, they don't exercise, so what does all that mucus do?
It sinks.
It just keeps sinking and sinking and sinking, okay? So they call it the blue bloaters because they're always a little bit cyanotic. COPD, this is the primary one that we deal with, right? So COPD, chronic obstructive pulmonary disease, emphysema, okay? So this is our alveoli issue, right? Our alveoli get worn out? Yes?
Yes.
Okay? So, what occurs in the alveoli, other than it gets worn out?
Gas exchange.
So gas exchange.
What occurs in a normal alveoli, or what occurs in?
What occurs in a obstructive pulmonary disease process?
Emphysema.
Yes, they clump together, so. that's
So
why-
is there elasticity in the
No.
alveoli? Normally,
Normally there
Yeah.
is,
They
and then they
expand,
use
increasing surface area.
Yeah, so you take a balloon, right? You blow the balloon up, you blow it past that point where it's really supposed to be, and then you let the air out, right? And then you blow the balloon up again. What does that do to the elasticity? Going from a new balloon to a balloon that's been used a bunch.
Makes it less.
Makes it less and less, right? So then, boom, now that balloon can get a little bit bigger each time, right? So now you take a big deep breath, boom, you got that balloon stretched out as extra stretched out, right? And then you cough. What does that do inside the chest wall?
Adds more pressure, more.
Increases in thoracic pressure. And what does that do to the alveoli that is now at its maximum stretch, weakened?
It could potentially pop
It
it.
could potentially pop, right? So what does that potentially lead to?
Pneumothorax.
It's only with fluids.
No? Filling with air. So you can end up with pneumothorax, right? So now you have a hole in your lung, in your alveoli, in your gas exchange. So now you're filling up with air. In pneumothorax, what happens if you keep filling that with air?
Tension.
Good pressure on your
So the lung will eventually collapse, right? Because it's just filling up there, filling up there, filling up there. So eventually the lung will collapse and do what?
Cause tension.
Tension.
What happens if you start pushing on the heart? Is the heart gonna like it?
No.
Okay? Is your respiratory drive gonna like it?
No.
No.
So you have to
Right?
increase something.
So what can we do? I mean, this is a non-trauma related patient. What can we do to fix this?
If it's tension, we would needle decompress.
Do tension pneumothoraxes only happen to trauma patients? No. So that's one thing that people have a very hard time doing is needle decompressing a COPD patient because they're like, no. There's not a real good reason. This is just a pneumo because that's just the assumption, right? But just know that the pneumothorax can progression into a tension pneumothorax in a respiratory. You just got to think of the mechanism of what's happening. You just continue to get air, continue to get air. If you leave a simple pneumo with an open valve, as in your open alveoli, and it doesn't heal, and it continues to fill over, depending on how bad it is, over a day, a week, a month, it can actually develop into a full tension pneumo. Or it can heal itself, seal it off, pressures will equalize, and it will heal itself with no treatment needed at all. Right? So just following, paying close attention and having that history of knowing, okay, yeah, you had a simple pneumo, and you went to the doctor, they told you that, and they said, hey, we're gonna monitor this. And now you get called a week later and be like, hey, this is what I got, and this person's in obvious respiratory distress, right? So this is where you can go through and start checking some of your famous threes and additional 2 extra credit points, yeah.
Can you explain what a bleb is?
A bleb, so a bleb is just basically the short version of you've popped your alveoli.
But just like one pop?
It could be one, it could be multiple, it's an opening of air into the chest wall. So now instead of having the closed circuit, you have an open circuit that is just allowing air to fill the chest wall cavity.
Into the visceral space.
Yes. So smoking is the most common, right? Because it damages alveoli. Other causes. One of the most common ones is prolonged exposure to chemicals. So one of the guys I worked with worked at a Doritos company, right? Nacho cheese Doritos. Yeah, that's
Amazing.
He says that his taste buds and his ability to smell things completely are messed up. And they had the N95 masks on. Like they wore N95 masks all the time. But just the overall residual particles when they go to the break room and stuff, because they're not wearing their masks in there. Just the overall residual effects of that, and he's constantly tasting nacho cheese now. He says nacho cheese was by far,
Good for him.
yeah.
Nacho cheese on everything.
Nacho cheese on everything. So he actually talked about, they called it the pink lung, Because what they would do is people would actually end up this phlegm, like they would be in the shower and they'd be blowing out all their sinuses and like hawking up mucus, and they're just like, yeah, like the joke was is they all had TB because it's spitting up the blood, right? It was a an orangish thing, but you start mixing that and diluting it, I guess it looks like TB, I guess. So yeah, so just because you're protected doesn't mean you're always protected from stuff. So just always assume like chemicals and stuff can get into your lungs and stuff and damage those alveoli.
So does he have lung issues, or is it literally just that he can't taste?
You can't taste. Yeah, doesn't actually affect.
Nachos.
That's where,
He just tastes nachos all the time. And this
isn't that where
was
popcorn lung came
almost
from?
10 years ago, 15 years ago, and he still tastes his nacho cheese. I mean, so, I mean, if you want to taste nacho cheese.
Rest of your life, your choice.
Outdoor air pollution, and then passive, secondhand smoke, all right? COPDers, right? Most of them are not new to the game. They've been there, they've been diagnosed, they have their own treatment. So if you get the call, what's the case?
They couldn't
That's
handle it.
bad.
Are we behind?
Yes.
Usually yes, okay? Usually they have Homo 2. Do they have it on all the time?
No.
Why do they take it off?
Because they don't like it. I'm going to the
They don't always take it
bathroom.
off to smoke, but a lot of times they take it off to smoke.
I hope they take it off
they
this.
take it off.
We hope, but I kid you not, people do not.
instead.
Oh,
They
man.
do not take it off, okay?
Boom.
So they take it off because it tickles their nose, or it irritates them when they sleep, right? But it's all those times it's like, hey, I'm gonna go to the store, I took it off, I had a long day, and I come back and I just can't catch back up, right? So what kind of meds are they on?
Steroids?
What kind of steroids? What's
Corticosteroids.
the most common one we hear?
Cortisone.
Okay? Inhalers, what kind of inhalers?
Albuterol.
Are they only on albuterol?
No.
Steroid inhalers. Steroid inhalers as well. Like they can have a multitude of things. So you're always asking what the med is. Don't always assume that it's albuterol. Okay? When they say that they've taken their inhalers, it could be something else that they've already taken. Okay? So like one of their steroid inhalers or a different med as well. So if they take something other than albuterol, can we give albuterol? Say they took 3 of their puffers before we got there of one of their steroid stuff. Can we give albuterol over the top of that?
Yes.
Yeah.
Yeah, absolutely. Like, so when we were talking earlier about if they've already taken inhalers and stuff like that, you gotta know what they're taking. Instead of just, hey, yeah, they took a bunch, they're amped up on this. It's like, yeah, it may not even be the same drug that they're taking, okay? Skinny and pink versus blue bloaters, right? So COPDers or what?
Pink. Blue bloaters.
So how are they gonna present? What are they gonna look like?
Oh,
They're skinny and pink.
that's emphysema.
So your emphysema is your pink puffers. COPD can as well be associated with bronchitis as well, so those are your blue bloaters. So your emphysema patients are gonna be your barrel-chested pink puffers, okay? So why are they skinny? Barrel-chested.
Burns a lot of calories, you know, the breathing out.
So what do they usually try and create for themselves?
Positive pressure.
Okay, so is their work of breathing hard more than the bronchitis people?
Yeah.
Yeah, so they're having to put extra thought and extra muscle tone into forcing themselves to create that positive pressure for themselves, right? To maintain what? Why are they trying to?
They have to pump out that outstretched
The VLA.
leg.
The partial pressure within the
So remember that elasticity, okay, is gone, so it doesn't just go back to the normal form, right? When it goes back, it shrivels up, right? So then you're not getting good gas exchange. So you have to create that in order to get full gas exchange, right?
They get ear trapping too, right?
Correct. So they are creating this constant pressure to maintain everything, to maintain those alveoli, to keep those open, so that the circuit stays intact, so they get full gas exchange. All right. Fail to recoil. So you got get damage to your villi. Let's see. So what do we do for emphysema? How do we treat this?
With a neb, not with CPAP.
Okay, so start with a neb. Medication we give is,
Albuterol and atropine.
okay, what else?
Oxygen.
What else?
Solumedrol.
Ooh. What's the indication for solumedrol? Did you guys just do solumedrol?
Not
Not
yet.
yet.
Not yet.
It's due tomorrow.
Oh, so the thing that's due tomorrow, you guys aren't like proactive in getting it done.
Not when we get assigned. to
Knowing that you were gonna talk about, lung and pulmonary stuff, you just decided to skip it.
Severe respiratory distress is expected asthma.
Okay. And what are some of the indications with that as well? Are recent or current steroid use. So basically they're presenting this picture for you that, yeah, they are COPD or they've been on steroids. A lot of times they're gonna be on a prednisone prescription that will be finishing up in the next day or two, and it's just not getting it done. So is somebody like that gonna go on another prescription of prednisone? Are there some people that are chronic prednisone users?
Yeah.
Yeah, they have chronic prescription for it. Okay, so we gave our NED treatment, it didn't work. Now what? NED treatment, you guys wanna give solumedrol?
Could you use a CPAP?
What are the indications for CPAP?
Pulmonary
CU,
What are
Pulmonary
the two
edema,
indications for
chronic
CPAP that we try and go with?
Pulmonary edema resulting from CHF.
Okay, that's one.
chronic bronchitis.
I'll
Or
give you a hint.
asthma.
So CHF and COPD. Okay, so those are two things that we give CPAP for primarily. Okay?
Yeah, but like, why can't you help the little homie out with the pressure deal?
No, we are. We are gonna help the little homie out.
I can't believe I just said that out loud, I'm so sorry.
And we all believe you.
Yeah, but we are going to. We're gonna use CPAP on this patient. Because what's wrong with his alveoli?
They don't look like
Right, so what do we need to do to help him get that gas exchange?
Stretch it out.
Assist.
We need to assist by keeping his alveoli open, remember? So they create the pursed lips, they're creating their own
Back.
positive pressure, right? To maintain that alveoli to stay open. So this is a perfect case to use our CPAP, okay? So we're gonna use CPAP at what dose?
Give me a 5.
10.
Would you call it dose or would you call it amount? Amount? What amount? What level of pressure? How many centimeters of water are we gonna use on our CPAP? 5, okay? So 5 for COPD, 10 for CHF, okay? Because we wanna increase the pressure for CHF because
There's blockage potential.
Water.
We're trying to push out the water.
we're pushing the fluid with it, right? So that's why we need to increase our fluid. Versus COPD, all we're doing is we're just trying to maintain the alveoli to stay open. So you guys have hit CPAP, right? So you got somebody, can we give homie a name? Bob.
Him.
Puff.
All right, we'll stick with little homie, I can see. All right, so how are we gonna?
What
So-
was your like rate, when you were talking about 5 versus 10, what are you talking about with CPAP?
Have you guys had it in the lab yet?
No.
All right, so basically there's two settings on your CPAP.
Autogram?
Now, it's a range that you increase the pressure based on the ability to dial up the pressure of your CPAP machine. Or if you have the disposable kind, you flow it as specific liters per minute, and it creates a specific pressure in your system of positive pressure. All right, so how you gonna talk to little homie here about this mask that you're gonna put on him?
It's gonna be uncomfortable, but they need to wear it.
Well, hopefully they already have a CPAP that they're sleeping on, so it's similar to that.
Oh, hey, good. Do you have a mask that you sleep with at home? That will help significantly, because then you'd be like, you know what, this is your mask on steroids. This one's way better than that one, right?
And they're like, I'm already on steroids.
And then they're just like, cool, like we're just gonna get you super jacked and pumped for this, and we're gonna get you feeling better,
Double
right?
steroids.
So coaching is one of the biggest things for this, of being able to get a mask on somebody that's not had the mask because they're short of breath, right?
Yeah.
And what does this giant mask come over the top of them feel like?
Pushing.
Claustrophobic and suffocating. So a lot of times what you can do is you can just come up behind them. You're holding the mask, you got it flowing, you come up behind them and be like, oh, Dustin, you're going to be my little homie here. Just be like, hey sir, I'm going to put this mask on your face. And here we go, and boom. You just hold it on there,
Oh, yeah.
okay? So you're
Until
holding
you
it on
stop
there,
shaking.
right? Don't try and strap it up the first thing and be like, okay, yep, I know it's just focus on breathing.
It's okay, Dustin.
concentrate.
Just relax.
It's all right, buddy. It's all right, my little homie. You just keep breathing. Okay? So you're holding it there, and they're going to struggle a little bit, and they're not going to like it, right? How many breaths do you think it's going to take before they start realizing, oh, hey, this isn't too bad?
One good one, hopefully.
5.
Yeah, I would say less than 5, and if it's going to work, they're going to basically instantly become compliant with you. They'll be like, okay, we good? All right, so this is what we're going to do. We're going to put a strap on here. It's going to go over your head. We're going to get this down. It's going to be really tight, okay? But we've got to keep it tight to keep that seal there. And then it's like, oh, okay. So you strap it down really tight, and then you give it a little wiggle. Why are you giving it that wiggle?
Make sure it's on right. On seal.
Tight.
Because what does a normal human being do as soon as you let go of something?
Wiggle.
They try and move, right? Because they're still uncomfortable and stuff's going on. So you got to give it a little wiggle to make sure that if they turn their head or do anything like that, that you don't lose seal. Because as soon as you lose the seal, it's going to start going, and it's just going to start free flowing again. You've lost all your positive pressure. All the pressure has to be directed down into the lungs in order to keep those alveoli open. Okay, good job, little homie. Glad you didn't panic. I'm glad you kept it together.
Are we worried about positive pressure rupturing one of those alveoli?
So at this point, you are not. Okay? So there are some contraindications for CPAP. One of them would be,
Tension pneumo?
oh, Yahtzee! Okay, little homie has a tension pneumo.
Well, that's not good.
Now, great. Now what?
Decompressing?
No decompress.
Okay. So think about that. Let's think about that.
That's
So we oh, I see a lot of,
We'll experiment, figure it out.
yeah.
Just keep the needle in.
Dude, so right there, I love.
Well, I was serious, like,
I
we'll
know,
figure it out.
that's what you do. So before you start experimenting on little homie, think about what you're accomplishing. Okay, so boom, you put a needle in somebody's chest. Okay, so now you have this needle stuck in the chest, right? So somehow they're happening to get air in there. So think there's air in there. So there's some sort of opening between your alveoli and out here. Okay? Now you put the CPAP in there.
Yeah, just blow it in the mouth and out the needle.
Yeah.
So think about it. So that's exactly what you have the potential to do if you immediately hook up the CPAP, because boom, you put positive pressure, boom, it can flow. So now it's going to flow into the alveoli, out the hole that's potentially there, into the visceral cavity, out the thing, and then it's like, oh, hold on, let's plug that for a little bit. Oh, now where's that air going again?
They're just like
Into the
gills.
cavity.
Now it's going to fill that cavity again.
At
Continuous
least they're not
pneumo.
worried
right?
about being suffocated anymore.
Right, yeah. Yeah, they just got this giant needle in the chest. That's what they're just, we're going to do. What? Okay, so some of the things with CPAP is they have to be aware of what's going on. Like they have to be conscious enough to be able to breathe and you be able to direct them, because altered LOC is a contraindication for doing this. With that being said, there will be times where you'll have somebody that meets the criteria for altered LOC, but their respiratory effort is good enough that if you put them on CPAP, they can recover to improve their mentation. Does that make sense?
Mm-hmm.
So you have to be able to look at their respiratory drive and how they're breathing to be able to to determine whether or not is this CPAP, are they getting enough gas exchange already to do any good, or what's our next step?
Innovation.
Using what drugs?
Is ketamine?
We're gonna
Oh,
call.
we jumped right on it.
Oh.
Boom. But we got ketamine, yes. Ketamine is a drug we go with. Okay. This is where you do play a little bit of the experiment game of being like, ooh, you know, technically you're altered, but I think, I'm guessing that your respiratory effort is enough to get you through. You're altered because you're hypoxic, because what's going on. If I give you a little bump, give the little homie a little bump, he has a potential
Wait,
to recover.
what drugs are we talking about?
We're talking about CPAP.
So
Yes.
for the CPAP, because you're talking about letting them try it first before you actually strap it on.
Yeah.
What if they just like, I've seen it before, they just like, nope, not doing it, and try, and they're like, I'm not taking this.
So then what do?
RSI?
TikTok, you only got a little bit of time left, and then I'm gonna take over, right? Like,
Yeah.
you have to really just continue to, it becomes a verbal judo game with people a lot of times.
Keep trying it.
Keep trying, it's like, listen, it's like, I know this, I know you don't like this, but this will help you. Continue to reinforce, what you can't do is you can't just give up and be like, screw you, I'm out, right?
It's here for a reason, so let's help you.
Yeah, and it's, I'll watch people that have no patience whatsoever, and they're just be like, well, okay, fine, die, I don't really care. It's like, dude, come on, hey, you can't say that.
They said that?
Yeah, because they're trying to get their point across, but they're trying to get it across in the wrong way, right? It's like, okay, well, you know what, you're gonna die. It's like, yes, there's a time and a place to tell someone they're going to die, but when they're anxious and upset and freaking out, and you're anxious and upset and freaking out because you can't do that, it's not the best time to pull that card, right? When they're refusing, when they got tombstone T-waves, then you can pull out the, you're probably not gonna make it through the
We call
night.
this tombstone right here, do you wanna?
Yeah. It's called a tombstone T-wave, right? So that's why we went to transport you, okay?
Nope.
No. All right, so COPD, with CPAP, and how long do we go with no improvement?
To the hospital.
They're just getting worse and worse and worse and worse and worse. They keep going. When do you start to experiment? Wait, have we given our solumetrol? Did we decide to get the solumetrol?
I thought we did.
No,
We
but
did.
we were on it, we did it.
So let's say, theoretically, we gave the solumetrol.
Did they have a pneumothorax in this?
No.
Okay.
Good. Way to keep track of all
There's
my,
too many.
all my,
Yeah.
yep, good.
But
Rabbit holes.
The solumetrol wouldn't really matter for acute respiratory distress.
No. Did I mention I'm allergic to respiratory steroids?
Good, because that's why we didn't
Well-
give Sarah some.
But you guys gave solumetrol?
No, we-
We were thinking about it, but we asked if you had allergies.
Right, so obviously you checked before. Luckily, I did not have any allergies. So you gave solumetrol. Solumetrol's not gonna do you any good, so now what? At what point do we?
and you could also nebulize through a CPAP, can't you?
Mhm.
You get epi?
So do a neb through a CPAP.
Epi for what?
Like,
Just
That's
to
not
be
really
epi?
doing
Just to throw epi?
just to jack them up.
It's a drug cocktail.
Just throw anything
it's
in
gonna
there.
real high.
But epi wouldn't do anything for emphysema, would it? Because we're
Yeah.
not having the
Good
obstruction.
information.
So you have alveoli issues with emphysema. You don't have bronchoconstriction issues.
Well, at this
But
point,
the
when you're
injuries are
thinking like, experiment, shouldn't you have RSI'd it on?
Oh, man, if you get to that point where you are thinking you should have RSI'd, you probably should have RSI'd, right? We talked about that with the crike, right? You at least, because how long does it take to get that stuff ready?
Like 5 minutes.
Wild.
Us, 1,000
It's
Well-
rapid.
Thank you, I get a 5 minutes over here, I'm like, we're talking about you guys. It took us like 2 hours to RSI our first patient, remember that?
1 hour.
That was
They're probably dead by then.
So you're gonna meet that fine line between when am I doing this and when am I not? And it's gonna be a total judgment call. If you see like respiratory volume going down, so you're seeing, so on your CPAP machine, as they breathe, it gives you a volume every time. It shows you, they're getting that much, boom, they're getting that much, and then you start seeing this needle drop in. That means their tidal volume is going down, right? So do you think the CPAP is working?
No.
No, right? So respiratory rate starts to drop, SATs are not improving. It's at that point you make that decision.
Have you ever considered doing BVM respiratory support while they're still awake without RSI?
But their
Yeah.
rate's not an issue.
So So
Because you're gonna BBM them before you,
if they're having issue getting tidal volume, then you can just bag them and
and
increase
just,
the tidal volume.
and just hang out and.
I mean, eventually, I guess you go work your way toward
Right,
the
so,
other
so,
side.
so as soon as you start bagging them, if you're bagging somebody,
You can't
RSI.
do that.
you're gonna be RSI, right?
absolutely.
So yeah, I mean, if for some reason you get enough tidal volume in there, their sides start to come up, they start to wake up a little bit and stuff, and then now maybe some of those neb treatments that you had given were starting to actually kick in, like everything's starting to come together for you, great. COPD patients, if the stuff didn't work to start off with, it's probably not going to work. And so this is where you end up.
So
Do
you-
most COPD patients come off the vent?
Off the vent?
Like as in,
Like,
if you intubate a COPD patient,
Oh,
how
no,
long?
they're not coming off.
So a lot of the times, it is a long, long duration for them to come off the vent, if they do come off the vent. One of the key things that you want to ask people is, have you ever had a tube put down in your throat to help you breathe? And if they say yes, are you behind already?
Getting it again.
You're like, okay, good, we're gonna prevent that. This is what we're gonna do. I'm gonna get really good at my skills really quick, and this is what we're gonna do, and we're just gonna start throwing that stuff out. All right? So all those things are all in the history, and so it's things that are very important for you to find out before you get to that point where that altered LOC, altered mentation, RSI is part of your consideration. Okay? Cool. You got something?
no,
Okay, good, because you don't get any time.
no, I don't want to.
Let's see. Alright, so that's what we got. Alright, so, ARDS. Right? Patients, what patients do we commonly go on that have ARDS? Where are they located
Hi, Al.
Retirement home,
that we commonly go on?
retirement.
Care facilities. These are the ones that you're gonna walk in and they're gonna be like, hey, this patient's got ARDS, this is the deal, da da da, you're transporting from here to there, for comfort measures, they're gonna get set up on hospice and then they're coming back, kind of thing. A lot of these patients are fatal. It's a non-related, heart failure pulmonary edema, it's non-CHF related, okay? So CHF has nothing to do with this, so your pump's working good, it's all lung related. Okay, so you got your fluid that's leaking smallest vessels into the lungs, tiny air sacs. So everything's filling up. All right? So here are some common causes. So you brought up the high altitudes, right? So you got high altitude, you got nervous system conditions, negative pressure pulmonary edema. Boy, what kind of thing would that be?
Negative pressure pulmonary.
Negative pressure pulmonary edema.
Is that gonna be like a drowning? Or a choking, blockage in the upper airway, choking?
Okay. So obstruction, so you got like a choking, and they're constantly trying to breathe, constantly trying to breathe. You have the increased pressure, and so where does everything go if it can't go up?
Goes
Everything's
down.
gonna start flushing out, right? So,
Oh, is that why skip breathing's dangerous?
skip breathing.
What? Yeah, where you like take a breath and then like hold it and then take another deep breath. You know what, never
Lung
mind,
pack.
as you were, we're gonna address this later, just keep going.
Okay. Pulmonary embolisms. We've talked about pulmonary embolisms.
Wait, go back to negative pressure. That's
Okay.
just our choking patient?
So you can have choking, you can have obstructions such as like massive amounts of fluid in your
Like drowning?
Yeah, you could have drownings, although near drownings are down here, but that's
Okay.
more of like you suck the water in,
Okay.
and then now you get secondary drowning.
Okay.
So the irritation, the dump, the massive fluid shift. Exposure to certain toxins as part of those inhalation things. You guys need to review your tests now? No, that's cool, that's cool.
They've already reviewed it.
No,
No
that's
one
all
got
right.
it.
They're
It's
all,
taken-
they
it's
all
taken
gotta,
listening.
they all gotta take a look. You can pass out. And then the last thing was that upper airway obstructions. Angioedema, we talked very briefly on that. That's the gal, there's like 2 or 3 of them in the city of Eugene that have angioedema. They have this massive, super expensive medication medication that they have, the husband hands you this piece of paper saying she needs this, and they have like 5 vials of this stuff, and it's like $1,500 per dose of stuff. And then you sit there and you hang out with her if she has an angioedema. Basically everything in the upper airways, everything lower airways, everything just swells shut. And it's an acute onset. There's no real specific what causes it. She'll just be sitting there and just all of a sudden she'll be like, I feel it. So she'll go, she'll take these 5 shots of medicine. I don't even remember what the name of it was. But if she catches it in time, then she stays home. If she doesn't, then it turns into a true emergency, and cric is one of the only ways to deal with that.
Because you can't get your...
Because everything swells completely shut up in, like, basically every vessel up in the upper airway just swells, and it basically swells completely shut.
You're saying this is somebody that knows this is coming on,
Yes.
called you to watch them take their meds, because if their meds don't work,
Then it's us. Yes.
you're my backup.
Yep, and you sit there for about 45 minutes, and they sit there and they're just like, yep, no, yep, okay, I'm good. No, hold on, maybe another 5 more minutes. And we're like, okay, like, you're the professional at this, like, you've been doing this multiple times.
Epi wouldn't work in that case?
I don't know, would Epi work in angioedema?
It's gonna open their airway.
Well, but you said upper airway, swelling.
So as a average normal first responder, like as a paramedic, that's what I would have done, had I not known that they have this special medicine that she specifically uses for this angioedema attack that she has. And so I would go with my normal swelling, allergic reaction type treatment. Like if I just came across her without knowing her history,
Or if she
I'm
is the
absolutely going to
first
go down
time.
that route. Right?
Is this like could it also be a first time finding out you have angioedema?
Yeah, I mean, there's always those times where you have that kind of stuff, and it's like, you just have to treat it as it presents the first time.
So was
inhalation-
there a conclusion on what epi would do? It would help or,
Well, you're gonna vasoconstrict, right?
right,
So I would assume that it would help.
but it's not in your protocol for it?
No, because we don't have a specific protocol for angioedema. We have a protocol for allergic reaction, and so we would present and treat that as
As
allergic
an
reaction, not knowing otherwise.
Obviously, they've tried that in the past, and I would assume
Right,
that
and it didn't
if
work.
she knows that this is gonna be an issue, that he probably doesn't either do enough or doesn't touch it at all.
But if you're looking
Just to treat it.
at the edema in the upper airway, are you talking epi 1 to 1000 IM, or are you talking epi through a neb?
So we don't have it for anything other than croup, but this would be a case where I would actually call the doctor and be like, hey, what do you think about giving a neb to this person via giving an epi neb, and then go that route and just kind of be guided by the doctor in there.
How would she breathe if she's got everything sealed up?
We hopefully get earlier.
I mean, it's an earth, we'd be getting to her soon.
Yeah, so if she so a lot of it is just gonna depend on if this is the patient that knows what's going on, or if this is the non-knowing patient. If the patient knows what's going on, then we'd be getting into him soon. The patient that doesn't know what's going on, then we're gonna get there for the initial respiratory distress, and we're still probably gonna be there fairly early into it, because somebody that doesn't normally have shortness of breath now notices, hey, I'm having a hard time. What's the natural reaction is to call 911 thinking I'm having some sort of allergic reaction. That's the go-to that people, when they have these new onsets of something, it's like, oh, I must be reacting to something. Did I start a new medication? Did I eat something different? Am I having some sort of allergic reaction? So more than likely, you're gonna get called for an allergic reaction, and then see, oh, yeah, this is something significantly worse. Let's see, aspiration, talked about that, post-surgical stuff, so wounds, tumor, blood, hemorrhage, upper airway strikes. How do we deal with the hemorrhage stuff? Suction, how do we deal with a tumor? Right? Take our scalpel down there and be like, oh,
Found it. Do the doctor.
Is this hemorrhage from a tumor that ruptured?
No, these are just different, so you have tumors, and then you have blood, you have different types of hemorrhage-related incidents. So you got a normal airway, upper airway, so like some sort of esophageal varices type thing where you're sucking in a bunch of blood, suction, suction, suction. Tumor, there's not a whole lot we can do for the tumors. What'd you say?
Just kind of go work with.
Yeah, work around it, work with it depending on where it's at. Think about that as you're placing, if you have to place advanced airways, what type of thing you're gonna have to place. Maybe a king tube would be a better solution where you're sealing off up and above and below, and you're creating a little passageway that's allowing that air to go, versus I'm gonna use my laryngoscope and lift up where maybe a tumor's at and cause more trauma and more damage. So it's just one of those things where just kind of working your way through the problem, experimenting, to be able to figure out how to manage it. Inhalation injury, our big concern here is what?
Constriction.
Constriction, right? We want to manage that before it's closed off. Okay, we've got to get to it before it closes off. And then how far down it gets, there's not a whole lot we can do for it. It's just making sure we can get that airway established prior to it closing off. Blunt trauma, whether or not we have to suction, crike, advanced airway, recognition of where the injury pattern is. And then, let's see, neuromuscular disease. So, all right, you guys got any questions? All right, you guys want to listen to some lung sounds real quick?
Yeah.